student. Hope you are staying fit and staying blessed, right? So now next let us discuss about gangrene. So the definition of a gangrene is a macroscopic death of a tissue with or without putrefaction. With or without putrefaction. So gangrene can be divided broadly into a wet gangrene, a dry gangrene, and a gas gangrene. Now what are the various common sites a person can go for a gangrene? Number one, it can be the distal part of a limb, most commonly associated with diabetes. So one can have a gangrene of the appendix. So appendix is an organ there inside the ileocecal junction. Gangrene of the gallbladder. So the gallbladder's function is to completely store the bile, and as and when it is required, the gallbladder, when the fat intake is there, gallbladder contracts and then delivers the bile into the duodenum. In the pancreas. So all these things can undergo gangrenous changes. What is necrosis? Some terminology you must know. Necrosis. A death of a group of cells is called as a necrosis. Then you have got another entity which is called as a slough. Slough is a piece of a dead or soft tissue. A piece of a dead or a soft tissue is slough. Now varieties of gangrene according to the causes. Now it can be a secondary to an arterial obstruction. So when the arteries get obstructed, so when should the arteries get obstructed? When there is a thrombus in the atherosclerotic artery. Suppose there is atherosclerosis normally occurs in the middle age group. So a thrombus in the atherosclerotic artery can definitely give rise to a gangrene. Or any embolus arising from the heart as in atrial fibrillation or in coronary thrombosis, that can again produce a secondary arterial obstruction. Arteritis, as you see in a diabetic arteriopathy or a diabetic neuropathy. Most of the complications of diabetes are, it can have an angiopathy, it can have a neuropathy, it can have a retinopathy, it can have a cardiomyopathy, it can have the complication can also be a nephropathy. These are all the complications of diabetes. Then Buerger's disease, I think we have discussed in our earlier classes about the Buerger's disease or the thromboangiitis obliterans. Or arteries can also be blocked in the case of a Raynaud's disease. We have discussed about the Raynaud phenomenon. Everything, a threadbare discussion has been done. So arterial shutdown because of a Raynaud's disease. Ergotism, methyl ergotamine is also given for migraine. So ergotism can also produce a gangrene. Or sometimes by mistake, when you are giving thiopentone, especially the anesthetist, if it is given into an intra-arterial, normally the drugs are given intravenously. Suppose intra-arterially thiopentone, THIOPNTN, thiopentone is given, that can also be produced again. Then the other causes can be infective gangrene. So when does infective gangrene occur? So what are all the causes? Boils is an infective gangrene. Carbuncle is an infective gangrene. Gas gangrene, again caused by Clostridium veg, Clostridium septicum, Clostridium edematans. So all these things can produce what is the gas we have discussed earlier. Then, most importantly, there can also be gangrene of the scrotum also can occur. Fournier gangrene, that's called as the Fournier', Fournier gangrene of the scrotum. Trauma can also produce severe gangrene. It can be a direct trauma or it can be indirect. So direct trauma, whenever a person is involved in a road traffic accident, a crush injury or a precious source, this can produce. Indirect trauma. Suppose a fracture has occurred, if it is impinging upon it, the fracture would have been impinging upon, for example, a popliteal artery. The popliteal artery can produce severe gangrene. Physical trauma like the burns, the scalds, moist burns, the scalds and frostbite, cold because of severe cold weather, frostbite. And chemicals, and chemicals also can produce, irradiation also can produce. Now what are all the various clinical features of a gangrene? So gangrene does not have any arterial pulsations. They may be very it will be very feeble or total absence of the arterial pulsations. The impediment of the venous return is not proper, and capillary response to pressure is not that means the vascular return is not good in the case of a gangrene. A loss of sensation can also be there. Loss of warmth, normally in case where the vascularity is good, it is warm. In the case of a gangrene, the warmth is not there, and definitely loss of function will be there in this case, right? Now when you see for the color of that area, suppose you take a gangrene on the lower limb, the color of the part when you see, it goes on to change into various shades of colors. Various shades. It can be initially it can be paler, then it can become a dusky grey in color, or it can be mottled-like appearance, or it can be purple in color, and then it will become very blackish in color because of the deposition of iron sulfide. Because of the deposition of the iron sulfide. Now when you go into the clinical types of gangrene, I told you dry gangrene, wet gangrene, and a gas gangrene. So dry gangrene, but here in this case, what our main common cause is an atherosclerosis. Because the atheromagnetic block is blocking the blood vessel, thereby going on for long duration, thereby they produce what is called the dry gangrene. So what happens to the tissues? The tissues becomes very desiccated. They become dry. They become very desiccated because of the gradual flowing of the bloodstream. For example, in atherosclerosis, and the affected part of the tissue can be dry. It can be wrinkled. It can be wrinkled, or it can be the color and the sheen may be lost. The color and the sheen may be lost because of the disintegration of hemoglobin and because of the decreased vascular flow to the area, and it can be greasy to touch. And more importantly, the next one is the moist gangrene. This moist gangrene, when does it occur? When there is sudden arterial obstruction is present. So when the artery is suddenly obstructed, either because a ligation of an artery or because of any embolus there, as in the case of the diabetes, that can produce a moist gangrene. Or, so what happens is, super meaning on that will be an infection and then a putrefaction of the tissue. The affected part is swollen and discolored. The affected part is swollen because of the edema and discolored, and most importantly, the epidermis, the skin, they may be having number of blebs over them, right? When you palpate, there can be a crepitus all over. Right? Now there is something called what entity which is called as a separation of a gangrene. So that separation of a gangrene can be because of a separation by demarcation. So you must know that there will be a nice demarcation, that's called as the zone of demarcation between the dead tissue and the vital tissue. So what happens is, indicate the surface is very hyperemic and they may be very hyperesthetic also. Then you have zone of granulation tissue there between the dead and the live, between the viable and the non-viable part, the dead part. You can have a nice zone of a granulation tissue. Followed that, what happens is ulceration follows that, and that can demarcate nicely the separation between the viable and the non-viable tissue. Whereas in the case of a dry gangrene, because of the slowing of the blood supply, what happens is the collaterals do develop in the presence of the gangrenous limb is there, which is hazardous to his hazardous to the person, better thing is amputation. Better thing is amputation. So limb saving attitude, one thing. Then arterial limb or everything depends upon the blood supply limb above the gangrene. Above the gangrene. So, for example, if a person had a crush injury, fallen under a lorry or a road traffic accident, then most important we have to amputate it. We have, because there's a gas gangrene also is there, then we will have to amputate. So the general treatment is, number one, if the person is an elderly person, he has a cardiac failure. Treatment of cardiac failure is a paramount thing. Patient is anemic, correction of anemia is most important thing. And most importantly, when you correct the anemia, the tissue oxygenation will improve. A perfect nutritious diet and control of the diet. Again, emphasize control of the diabetes is by giving insulin, doctor. Insulin is the most. Don't give him oral hypoglycemia. You start off with insulin, and most importantly, broad-spectrum broad-spectrum antibiotics. The pain can be controlled by non-addictive drugs, any of this, and anti-inflammatory. All these drugs can be used. Right? You have to choose between patient to patient what anti-inflammatory drugs you have to use this person. And most important, local treatment will be you will have to take utmost care of the affected limb. And the desiccation and all, the pain can be relieved by having a fan near the involved limb. And protection of the local pressure area. For example, malleolus there. You just protect the malleolus by putting nice cushioning behind it. Now the various types of gangrene, like a diabetic gangrene, here what are the three important factors. So diabetic person, uncontrolled diabetes. So he can have, most importantly, if it is an uncontrolled diabetic elderly patient, he also will have an associated atherosclerosis with them. So as a consequence to diabetic vasculitis, diabetic neuropathy, all these things, what happens is they can produce severe trophic changes resulting in peripheral neuritis, trophic changes, and severe atherosclerotic plaques can block the various arteries, and the urine sugar is elevated. What happens is the blood sugar gets accumulated into the glucose-laden cells. The glucose-laden cells are highly resistant to infection because the glucose is a basic fat in the steel. When you go back into your pathology in your earlier days, why the diabetes, the delayed cooling, because the leukocytic adherence is lost, is minimal or lost. And all these neuropathic factors produce what is called severe superadded infection, and thereby the severe damage to the tissue, and the muscle involvement will also be there. As a consequence to which they develop neuropathic joints, and the blood supply to all these areas will be decreased, thereby they produce a gangrene. So initially it will be ulcer formation, or it will be a boil formation, or it will go on transform into a diabetic foot gangrene. So what are the clinical examinations you are supposed to do? You must do a urine sugar for this. I know you all urine sugar is done by the Benedict's test. You must do see for the fasting blood sugar, the postprandial blood sugar, and the random blood sugar. And always palpate for the peripheral pulses. Always palpate for the peripheral pulses. Lower limb is the posterior tibial, is the dorsalis pedis, the popliteal, and the femoral artery. Must always be this thing. And most importantly, ask for, if it's a DAO patient, ask for any intermittent claudication or claudication pain. And treatment diabetes to be controlled by giving insulin and most importantly broad-spectrum antibiotics. Send any necrotic tissue for culture and sensitivity to the Department of Microbiology and get your specificity of the antibiotic which is to be used. And most importantly, if it's a direct traumatic gangrene, the local injury to the issue, severe pressure strokes are there. What you have to do is, most importantly, if the gangrene is this thing, you will have to go and amputate the gangrenous limb. The bed sores are another form of prolonged bed sores can result what's called as gangrenous formation, various areas. Bed sores is also called as a decubitus ulcer. The nurse has to go on frequently shifting the posture of the patient, frequently, so that the pressure is not there. And most importantly, you must see for the ripple beds. You will see for the ripple bed. All these things must be taken care of when you are treating us. Then the last one is the indirect traumatic gangrene, where what happens is it can be a fractured thing which can be impinging upon a major vessel like a popliteal artery. Or because of this vessel, because of the fracture segment which is impinging on the blood vessel, when the flow is decreased, it culminates in the formation of a thrombus. Thereby that thrombus can lead to what is called the gangrene formation. Or it can be because of the ligation of the major artery, or most importantly, it can produce all other philosophies. Or if a person during surgery, if a tourniquet is tied to the area of operation for long durations, that can produce a severe gangrene. But the only thing is, here when it is acute, there is no time for the collaterals to develop. So here what we have to do is immediately remove the cause. The thrombus is there, remove the thrombus. The tourniquet, because tourniquet time is most important. The anesthesia will always be announcing 5 minutes, 10 minutes, 20 minutes of tourniquet time. So you must be ever vigilant when you are operating on such people. So and most importantly, you must reduce the fracture fragments and reduce the fracture which is impinging upon the vessels. This is about the various aspects of the gangrene. In short, we were discussing about the abscess. See, the abscess can be, I discussed about abscess, how it should be drained, modified different method of drainage. The abscess has been stratified as a pyogenic abscess, a pyemic abscess, and a pyogenic abscess, pyemic abscess, and a cold abscess. Pyogenic abscess whenever you see the acute condition. So that is we put an incision and draining. Depends upon, suppose if it's in the carotid region or in the axillary region, it will be a modified Hinton's method drainage abscess. But cold abscess on the contrary, so pyogenic abscess. Now when I go into pyemic abscess, this is because of a septicemic process which is going across the body. So septicemia can give rise to multiple pyemic abscesses which are very deep seated. And most importantly, we will have to drain all these abscesses. We will have to drain all these abscesses. Whereas cold abscess, which we discussed that way, again, you have in the case of a tuberculosis, or can occur in the case of a actinomycosis, or in the case of a motheromycosis. But cold abscess, commonly seen in our country, is a cause of an extrapulmonary tuberculosis. Tuberculosis, the pathogen, mycobacterium tuberculosis, the most important causative organism in the case of a cold abscess. Here the stages are the stage lymph node, one of the cervical lymph nodes get enlarged. That's called the stage lymphadenitis. And then two lymph nodes can get together, 2 or 3. That's called the stage of periaginitis or matting. Or if it is not treated here, it goes into the formation of a stage of a cold abscess, or it can go into the formation of a stage of a cholesterol abscess, or a stage of a tuberculous sinus formation. Here you must search for the underlying lymph nodes, do an FNAC, you do all the hemoglobin TC, T3, ESR, 1, 2 test, all this thing. ESR will be definitely elevated in the case of a tuberculosis. And then you must give him, you do an FNAC. When the FNAC is sent from the Department of Pathology, or if the lymph node is there, you do an excision biopsy and send it to the pathology. Suppose you get the characteristic synchronon is the epithelioid cells and the Langerhans cells in the case of a tuberculosis pathology. Once you get that, and the tuberculosis culture if you have, that you send it to microbiology. The tuberculosis culture media is the Lowenstein-Jensen media. It takes about 6 weeks for us to get the result. But if you can get a pathological report like a epithelioid cells is a characteristic, then you start them on